Okay, we are continuing our lecture about the basic of the ECG. We are going to talk now about the ST segment. ST segment is flat. That means it is with the isoelectric line. That is a normal ST. Any elevation or depression of ST segment by 1 millimeter or more is significant. We can determine the ST segment change elevation or depression from the J point or junction. J point or junction. This is the point between the QRS and ST segment. Okay, here are some variable shapes or different shape of ST segment elevation that occur in the setting of acute myocardial infarction. Uh, as we see here, just to here, this is the isoelectric line here, and so this is ST elevation here. This is ST elevation. It looks like that is a concave like that, and here it is a curved shaped. This ST elevation also curved shape. ST elevation. This is different or various shape of ST segment elevation. For example, uh, here if you see the elevation is more than one millimeter. It is more than 1 millimeter, so it is significant. Here we see here the elevation, I think 3 or 4 big square. About ST depression, here you see here this is ST depression. This is the isoelectric line, and here so this ST depression, and it is about here this is a big square like this one. This is big square, and the elevation here is about 2 millimeter or 2 small square, and so it is significant. Also we have different shape of ST depression. It could be as we see here, it is a reverse tick or hockey stick, or here you can say is Salvador Dali mustache. This is Salvador. This is an artist. Is a serialist and artist, and that is his mustache, and what the ECG looks like his mustache. Okay, this is significant ST depression. T wave, a normal T wave, it's asymmetrical. It is an asymmetrical. The first half having a gradual slope than the second. They are two slope. The first half is the gradual than the second. And it should be at least 1/8, but less than 2/3 of the amplitude of the R wave. We compare the T wave with the R wave. The normal should be less than 2/3, and it is about 1/8. 1/8. Uh, it rarely exceeds uh, too big too big square over 10 millimeter. T wave follow the direction of the QR. S deflection. If it is positive, it will be positive. Negative, it will be negative, usually. And abnormal T wave are usually symmetrical and tall and peaked biphasic or inverted T wave. You should differentiate between ST segment and T wave, and I will explain this. Here are T wave in a normal ECG. As you see, it is symmetrical, and it is usually follow the deflection of the preceding R wave. Okay, and in AVR here usually it is inverted. It is normal. What is the UF? If I have UF, it is related to after repolarization that follow repolarization. So it is normally after, it comes after T wave. It comes after T wave. Here it is the U wave. Has the same direction as T wave, and it is less than uh, uh, 2 millimeter. It is round and symmetrical, and the positive in lead 2. It is usually prominent in cases of hypokalemia. Okay, ST and TE wave abnormalities usually accompany ischemic heart disease and acute coronary syndrome. So we should give a glance to acute coronary syndrome and see what the evolution of ECG change that occurred, especially in acute coronary syndrome, ST segment elevation. And uh, a brief glance about blood supply to the heart. Uh, this usually the myocardium of the heart is supplied by the coronary arteries. As you know, we have the left coronary and right coronary artery. Both these arteries arise from the root of the aorta, the left coronary artery from the left coronary sinus, and the right coronary from the right coronary sinus. This is just above the cusp of the aortic valve. Okay, here the left coronary artery, you have the left main coronary artery that arises from the left coronary sinus, then give up the left main, which is divided into uh, uh, left circumflex, and left anterior descending artery. Follow the arrows, and this is the left circumflex here, and this is the here this one which runs this way. This is the left anterior descending artery. The left anterior descending artery, it runs in the anterior part of the heart in the uh, anterior interventricular groove, and so it supply the anterior part of the left ventricle and give diagonal branches that supply the lateral wall. This is one diagonal branch, and septal branches, small septal branch that supply the left interventricular septum. And the left circumflex artery, it goes posteriorly in the AV groove, that is the anterior atrioventricular groove, that is the groove between the atria and ventricle, and tabulate the posterior part of the left ventricle and the inferior part. This is when this is a dominant when the left system is dominant. Uh, but sometimes when the right system is dominant, this part of the heart, the inferior part of the heart, is supplied by the right coronary artery. So the right coronary artery, here it is arise from the right coronary sinus, and it goes uh, in the right part of the AV group and supply the right ventricle, the right ventricle, and sometimes when it is dominant, it supplies the inferior and the posterior wall of the heart, as we say, and give and supply the part of the conductive system. We know what is the anastomosis. With the anastomotic, that is there will be a connection between these blood vessels. When one blood vessel is occluded, this anastomosis, the anastomotic part may take its role in supplying the part that is jeopardized by the closed artery. Venous drainage of the heart, the territory of the venous drainage runs in the same way they all drain into the coronary sinus, which is then drained to the right side of the heart. This is briefly about the blood supply of the heart. We are talking about ischemic heart disease. We should know how the blood is, how the myocardial is supplied. Uh, So why the occlusion of certain vessel will give a characteristic ECG change indicating the site of that artery. Okay, if you go back again to ST uh, ST segment here, an example of this is a normal ST segment here. This is the ST segment. This is a normal ST segment between the QRS complex and T wave. This is an elevated and this is a depressed. Uh, okay, and about T wave, you say it's here is a T wave, the normal uh, T wave. It is an here upright and asymmetrical, and we have normally the T wave is inverted in the AVR. Here, this is lead one, and this is the AVR. Acute coronary syndrome, we talk it about it is a constellation of symptoms. That means symptoms related to the obstruction of coronary arteries, merely chest pain, and this is being the most common symptom, in addition to nausea, vomiting, and diaphoresis, sweating. And the other symptoms may include dizziness, fainting, and even the shortness of breath. Sometimes we have epigastric pain and chest pain concern for acute coronary syndrome is often radiate. This is to the left arm or angle of jaw. Its character could be a pressure-like, burn-like, or constricting in character, and it's usually associated with nausea and diaphoresis. Uh, this chest pain categorized into typical and atypical chest pain. This is previously, but now it is categorized into cardiac, non-cardiac, probable cardiac, and non-cardiac, three categories. This is according to the presence of three characteristics of this chest pain. One, this chest pain should be, we find the three criteria, we say this is typical or cardiac chest pain. Number one is this substernal or retrosternal chest pain. Substernal or retrosternal chest pain, this is the side. Number two, uh, it is increased by exertion or emotional stress. Number three, it's relieved by rest or nitrate. If we find these three criteria of chest pain, we say this is cardiac chest pain. If we found two criteria, we say this is probable chest pain, and only one criteria, we say this is non-cardiac chest pain. So, what's acute coronary syndrome, and how we classify it? This based on ECG plus cardiac enzyme. We can classify acute coronary syndrome into three main categories. Okay, so ECG is the cornerstone in the diagnosis of acute coronary syndrome. Uh, is acute coronary syndrome, ischemic heart disease, especially acute coronary syndrome, and every patient present with acute chest pain. First thing we have to do an ECG, and you should do it within the first 10 minutes of arrival of the patient, and should be interpreted by an experienced medical doctor or staff. Okay, so ECG and cardiac enzyme, you can classify it to ST segment elevation. You see here ST segment elevation. This is based on ECG only. ST segment elevation, myocardial infarction. That means we have did an ECG and found that there is a ST elevation. Plus, definitely ST elevation in setting of acute coronary syndrome means total occlusion of the coronary artery territory. So definitely there will be a necrosis, cell death necrosis, and there will be an elevated cardiac enzyme. Number two, we have non-ST segment myocardial infarction. Here there will be an ECG change like ST depression, TUF inversion, or even normal ECG plus elevated cardiac enzyme. Elevated cardiac enzyme means there is cell necrosis. Unstable angina, we could find a non-specific ECG change or even ST depression or normal ECG plus normal cardiac enzyme. So this is acute coronary syndrome. We have ischemic heart disease, different ischemic heart, acute coronary syndrome, and chronic coronary syndrome. But now we are talking about acute coronary syndrome and the importance of the ECG in diagnosis acute coronary syndrome, especially ST segment elevation, myocardial infarction, or ST segment elevation, myocardial infarction. Why ST segment? There is elevation and inversion. Okay, this is depend on the what's happened in the coronary artery. If we have total coronary artery occlusion and there is a transmural injury, that means the whole thickness of the myocardium is dead, there will be ST segment elevation. And otherwise, if we have partial occlusion of the coronary artery as happening in ST segment, there will be subendocardial injury only here, and you see here subendocardial injury, the whole thickness is not involved, so there will be ST depression. Okay, ECG is the first point of entry into acute coronary syndrome algorithm. So this is again emphasize the importance of ECG. It could be abnormal or normal, neither 100% sensitive or 100% specific for acute myocardial infarction. We could have acute myocardial infarction with normal ECG. Single ECG for acute myocardial infarction, the sensitivity is about 60% and the specificity about 90%. And it represents single point in time need to be read in context. At the same time, do it, we have to interpret the ECG, and it represents a single point in time. That means we can repeat it after 10 minutes and it may change after 15 minutes like that. So serial ECG is important. Normal ECG does not, as I said, exclude acute coronary syndrome, and we have about 1 to 6% and proven to have an MI with a normal ECG, and about 4% with unstable angina with a normal ECG. Then, if we talk about guidelines, uh, the initial 12 lead ECG goal to door, that means goal door to ECG time should be 10 minutes. What does that mean? That means the ECG should be done in about 10 minutes from the arrival of the patient. Goal door to ECG time. And should be read by experienced doctor. This is class 1 recommendation. If the ECG is not diagnostic or high suspicions of acute coronary syndrome, we have to do serial ECG. I already mentioned this. Also, this is class 1 recommendation, and about 15 to 30 minutes we have to repeat the ECG. Also, we can do an ECG adjunct leads. That means the posterior leads and the right leads. I already explained this in the previous lecture. Continuous 12 lead ECG monitoring could be a reasonable alternative to serial ECG. Uh, serial ECG, which can be done every 15 to 30 minutes. Okay, how to evaluate for ST segment elevation? As I said, first we have to look at the J point. Uh, this is, and then to identify where the isoelectric line is noted to be, and to compare the level of ST segment to the isoelectric line. So we have to locate the job point from which we can determine the ST elevation, and we have to identify the isoelectric line, and we have to now to compare the level of ST elevation from this isoelectric line. Either elevation or depression is significant if more than 1 millimeter. That means one small box, uh, and it should be seen in two or more leads facing the same anatomical area of the heart. Okay, what does that mean? That means, for example, if we look at the lead that facing the inferior area of the heart, we can see that the change will be definitely in lead 2, 3, and FVF, for example. And the elevation should be like that. That is contiguous lead facing a specific area, the same anatomical area of the heart. The elevation will be A, or the depression in B, in that facing that specific side of the heart. Okay, elevation in certain people, for example, in a young male less than 45, uh, it should be more than 2.5 millimeter, especially in lead V1, V2, V3. Sometimes we have a normal elevation less than that in this young male. Uh, Here, and the key point and how to locate it, and how we can identify the isoelectric line in sequences series. So we have to identify the J point. Here, this arrow mention the J point. So this is the J point here. And so now we identify the J point, and after that we should identify the isoelectric line. This is the ST segment here. This is iso from here. This is the isoelectric line, and now here this is the ST segment. It is flat within the isoelectric line. So after that we can determine the elevation or depression from the isoelectric line of the ECG. Uh, it is the ST elevation evaluated about one small box after the J point, right, 0.04 from the J point. This is the J point, one small square. We can evaluate the ST segment change elevation and depression. Okay. Next. Okay. This is some description of ST elevation, and that the cuff shape usually indicate acute injury. Here it is here. That is the convex one. That is the frowny, or this one, the frowny one, the angry one, and this is a cuff shape. ST elevations usually indicate acute injury. We have the smiley, that is the concave shape. It's usually benign, especially if the patient is asymptomatic. It would be a normal variant. The concave ST elevation here. This is the J. This is a J point here. This is a J point in here. That is a J. The convex one here. The convex down, and the concave up. Okay. That is a cuff. So when we find it's convex down, it usually indicate an injury. Okay, evolution of acute myocardial infarction and the ECG changes that occur during this. Uh, we have first the normal ECG, that is a pre-infarct, that is the normal ECG here. And the A one, this first. Then B, usually they will be first tall T wave. This is the first few minutes of infarct. It will be tall T wave. If you see here, this the normal T wave, it should be less than two-thirds. Now it is more than half of the preceding R wave. This is the R wave. Here is and this is the ST. It is more than half Now this is total abnormal T wave. This is okay in the first few minutes of myocardial infarction. Uh, After this total T wave, there will be ST elevation. That means the injury that occur. This is after 1 hour, and then we have an elevated ST elevation that we will have inverted T wave ST elevation, then T wave inversion. That means is in 24 hour, and thereafter there will be uh, the formation of a Q wave and T wave inversion, and the Q wave will be a permanent. We find the Q wave, that means we have an old myocardial infarction. That's the sequence that occurred within 24 hours and more for the evolution of acute myocardial infarction. Okay, go back to anatomical group. That means the lead that facing the same uh, lead that facing as anatomical one anatomical site of the heart. Regarding this here, for the septal that we have lead V1 and V2. These are called the septal lead. That these two leads facing the septal interventricular septum. Okay, for the lateral we have in the lateral lead we have both lead 1 and AVL and V5 and V6. For the anterior we have V3. I will make a cycle for this. V3 and V4. This is for the anterior. For the inferior we have 2, 3 and AVF. This is the lead that faces the inferior part of the heart. AVR facing none. Okay, this is the coming or repetition of this. This is the anterior with the purple color. You see V4 and V3 and V4 for the anterior. V3 and V4 for the anterior, and V1 AVL and V5 V6 for the lateral. And the green color here, that is the inferior lead 2, 3 and AVF. That is the anatomical group, the whole of them. Okay, non-STEMI, ST depression about here very significant in ST depression, even about 0.5 millimeter at least, or TUF inversion about 1 millimeter at least without QF in two contiguously. That contiguously, that they mean they are facing the same anatomical area of the heart. With the prominent R wave or RS ratio more than 1. This is non-STEMI. You have that, you can see that either ST depression or T wave inversion or even normal ECG. This elevated cardiac enzyme. Isolated T wave inversion can correlate with increased risk of MI. That myocardial infarction may represent Williams syndrome, that is critical LAD stenosis, and if it is more than 2 millimeter inversion in the anterior pericardial lead may indicate critical LAD stenosis. That is what I mean by Williams signs. We have Williams syndrome, that is we have type A and type B. For type A, that is the inverted T wave, and for type B, that is the biphasic T wave, deep inverted T wave more than 2 millimeter in the anterior pericardial lead, that lead 1 and V1, V2, V3. Okay, unstable angina. Here we have may have non-specific or transient ST segment depression or elevation with negative or cardiac enzyme, or it could be normal ECG in case of unstable angina. Okay, here are some few ECG about myocardial infarction. Look here, evolution of acute anterior myocardial infarction. Anterior, that means the mainly involved lead here, V3 and V4. We have also V2, so it is, and V1, so it is, this is V3 and V4, and even V2, and you see it is a cuff shape. So, and we have some ectopic here. This is ST elevation, myocardial infarction. That is, you can say, anterior septal, that involving the anterior and septal lead, and also lateral. If you this there is elevation in the lateral lead. So this is very extensive. AMI lateral lead, that means it's involving lead 1 AVL, V5 and V6. So this is very extensive anterior septal and lateral myocardial infarction. Here the same, and evolution, and here you see ST elevation in V6, V5, V1 and AV also. This is lateral. Okay. Okay, here this is the inferior lead involving lead 2 and 3 in addition to AVF. Where is one addition to AVF? This is AVF. This is a inferior myocardial infarction. Okay, we have can talk about the metabolic fact or effect and drug effect on the ECG. First, hyperkalemia can produce a consequences of change, not only one change. So there is first will be narrowing, beginning by narrowing and peaking. That is called tenting tall T wave. And there may be some AV conduction disturbance, like for example, first degree AV block. Then there will be diminution of the P wave amplitude. So the amplitude of the P wave will be diminished or even disappeared. And after that, we have widening of the QRS interval, and that is means the sinusoidal, and the QRS will be very wide, and you will see this more that wide. That means more than 3 small square in the wides. Cardiac arrest is a slow sinusoidal type or mechanism, and that is called sine wave pattern, and then even systole. Here's an example of that here. That is the especially we find this sine wave pattern that indicate severe hyperkalemia. As we see here, this is QRS now is very wide, and maybe then bradycardia. Yeah, this is a hyperkalemia again, very tall T wave. If you see it here, T peak 10 T wave. This is indicating acute hyperkalemia, and this is definitely this is a sinus the pattern you see here, sinusoidal pattern. Now the QRS complex is very wide. This is a pre-arrest situation, and it is very dangerous, and we have to act very quickly to reverse hyperkalemia. About hypokalemia, I told you before, it's usually prolonged the ventricular repolarization, so it appears as prominent U wave. Prominent U. Hypocalcemia typically prolong the QT interval. If you look at the, especially the ST portion, will be the QT interval will be prolonged. The corrected QT interval will be more than 450. Hypercalcemia do the reverse shorten the QRS interval. And digitalis effect it shortens the QT interval, and often with the characteristic scoping of the ST segment, ST wave change. That scoping, that ST depression or the inverted the tick sign that we see before in the picture of that artist Salvador Dali mustache. That is the effect of the digitalis. That means the patient is taking the digoxin, for example. Here is the hypokalemia. Usually we have prominent U wave. You can see it here. This is prominent U wave. It comes. The U wave usually come after T wave. Here, this is if you see here two deflection. Huh? So this we have U and you have T and then U wave. That is the prominent. Hypercalcemia. It shortened. See this ECG example. It shortened the QRS complex. The opposite occur in hypokalemia. The prolongation of the QRS, the formation of the ST or the interval of the QT interval. The QT interval is prolonged in hypocalcemia. Now we can talk about bradyarrhythmia in a very quick way. Although you have sinus bradycardia or junctional rhythm, and we have cyanoatrial block and atrioventricular or AV block. Here, these are four categories. What's occur in sinus bradycardia? Sinus bradycardia usually the problem is only within the heart rate. The heart rate will be less than 60, but we have normal P wave and P wave morphology and PR interval and the QRS complex interval and morphology. As you see here in this example, the heart rate, if we use the 300 to count the heart rate, here it's counted to be less than 100 security. So there is a bradycardia and the rhythm is regular, and the P wave, as we say before, each QRS complex we have identical P wave, and the duration of the PR is normal if it's less than 20 uh, millisecond, and the QRS duration less than 0.12 second, it is normal. This is sinus bradycardia. Junctional rhythm. Here the heart rate, because the electrical impulse comes from the AV junction, the rate will be around 40 to 60, and it's usually regular. The problem here is with P wave. It is inverted, absent, or after the QRS complex. You see here, we have no P wave here, but it is the rhythm is regular. What is regular? That means RR interval are equal. The interval between every RR wave is equal. And the problem here, no P wave, or maybe inverted or come using the QRS complex. So this is junctional rhythm. Cyanoatrial block. And what's the problem in cyanoatrial block? The impulse is here blocked within the cyanoatrial node. So there will be no atrial depolarization. That means there will be absent P wave when there is a sinus arrest. When the sinus node is not firing an impulse, there will be no P wave. But when it fares normally, as we see in the coming ECG, there will be a P wave, and that followed by QRS complex, as you see here between the cyanoatrial node and surrounding myocardium. Type here we have, this is a P wave, and this is the QRS complex. Then there is a sinus arrest, no P wave firing, so there is no QRS complex, so it is absent here. This is called what's called cyano or sinus arrest. It occurred irregularly and unpredictably. Irregularly, that means it comes and goes like that. It can present in young athlete as digitalis, or in a patient with hypokalemia, or in patient with sick sinus syndrome. Uh, Talking about AV block, we have further subclassified to first degree and second degree and third degree AV block. We will see each one in a separately. The first degree AV block, in the first degree AV block, there there will be a delay in the conduction through the conducting system. That's mean. So that's the impulse. It goes through, normally through the normal conductive system, but it is very slow. So there will be prolongation of the PR interval. The what does that mean? The but the that the PR interval it will be abnormally prolonged. It's more than 20 millisecond or 0.2 second, and the all P wave are followed by the QR. All P wave are followed by QR. So the problem here is only prolongation of the PR interval. Everything others are normal. It's usually associated with acute rheumatic carditis, digitalis effect, and in setting the patient taking beta blocker or excessive vagal tone, it could occur in ischemic heart disease, or there is an intrinsic disease with the conductive system. This is an example we have here. You see, we have a prolonged PR interval. It is about 0.228 millisecond, uh, more than one big square. One big square is equal 200 millisecond, we said before, or zero point 0.2 second. What about second degree AV block? Here, the duration of the PR interval will be normal. There will be intermittent failure of the AV conduction. And the impulse here is blocked in the AV node. We have two types, Mobitz type 1 and Mobitz type 2. That is, you can talk about them. Mobitz type 2, one is the what's called Wickenbach phenomena. Here will be, we have a progressive prolongation of the PR interval, then peak drop. Okay, we will see this here. Mobis type 1 here, this is an example. Okay, look at P wave. Look at P wave in this strip prism. Take it from here. This PR interval here. Now in the second, it is a little bit longer. And in the third here, we have a drop. We have a P wave, but it's not conducted P wave. There is no QRS complex here. There should be a QRS complex here. So this is a progressive prolongation of the PR interval, then drop or no conduction after that. There will be a P wave, but no QRS. So there is no conduction uh, here in the third. The PR interval begin normally, then prolong progressively, then there will be a drop of the QRS complex. Sorry. For Mobitz type 2 here, that's not occur like that. There is no progressive prolongation of the QRS or of the PR interval. It is normal. PR interval the same, but there is intermittent blockage. We have a P wave, but no QRS complex. This is a difference between Mobis type 1 and type 2. In Mobis type 1, we have prolongation of the QRS, progressive, that means PR interval increase and then it drop. But here, the PR interval is normal and there is a drop. This is the difference. You see here, this is a drop. That's mean no, but the P wave, but no QRS complex. This is simply about Mobis type 1 and type 2. Okay, what about third degree heart block? Third degree heart block, also called complete heart block. Here we have complete AV dissociation. What that means? That means there is no relation between the P wave and the QRS complex. And the junctional escape rhythm is about 45, and the PP interval vary because of the ventricular phasic sinus arrhythmia. That means what we have here, there is no conduction from the AV node to up to the ventricle, and see here there will be a complete dissociation between P wave and the QRS complex. You see here, this is a P wave. This is another P wave. Then wide QRS complex. This is wide QRS complex. Again, here we have P wave and this is P wave. There is no relation between P wave and QRS complex. And usually here we have a ventricular firing. That means the impulse comes from the ventricle itself. So if the ventricle works as a pacemaker, the rate usually will be less than 45. These patients they have bradycardia and they are very symptomatic. They are bradycardic and symptomatic, and there is no any relation between the P wave and the QRS complex, and the P interval vary because, and the RR interval usually it could be as we see here, could be regular, and R interval are regular, but the P interval are not regular, and there is no any relation between the QRS complex between the QRS complex and the P wave. That is, there is a complete dissociation between both of them. Yeah, this is here. This is paste rhythm. You see, this what's called that here. I give you this here. This is a spike. This is a pacemaker spike. The last one here. Sorry. Uh, the last ECG here. This is paste rhythm. This is how the complete heart block treated by putting a pacemaker, an artificial pacemaker, to treat the heart rate, and this is why this is a spike appear here. This is a paste rhythm. We call it paste. Okay, now we can talk briefly about arrhythmia. Arrhythmia, that is, in general, what we already talked about is the bradyarrhythmia, and now we have the tachyarrhythmia. That's we can subdivide it into supraventricular and ventricular arrhythmia. That is according to the site where it arises from. It either arises from the sinus node, or from the atrial cell, or the AV junction, or from ventricular cell. If it is from sinus node or from atrial cell, here we can call it supraventricular arrhythmia, or if it's from the AV junction, it calls the AV or junctional arrhythmia. It called junctional arrhythmia. Below the AV junction, it is definitely ventricular arrhythmia. This is according to the site from which the arrhythmia arises. I mean by arrhythmia rise site, that means the pacemaker or the firing impulse come from where? Either from cyanoatrial node, this is a normal sinus node. We find this sinus node, it's called sinus arrhythmia or sinus tachycardia, that is normal. And if from the atrial, it would be like atrial fibrillation or atrial flutter or supraventricular tachycardia. And an AV junction, junctional tachycardia, ventricular cell, it is ventricular tachycardia. In a simple way, here an example, we want to count rate here. We have it is about 30, the rate here about 30 using the 300 roll. And the regularity, now here you see it's regular, and the PWF is normal, and the PR interval is about 0.12, and the QRS duration about 0.10 seconds. So this is sinus bradycardia, for example. and here the rate is about 130 and it is regular, and the P wave normal, and the PR interval 0.15 normal, PR duration normal. This is sinus tachycardia. Okay, premature atrial contraction and premature ventricular contraction. Premature atrial contraction, it is a deviation from the normal sinus rhythm. These are ectopic beats, okay, originate in the atria, but not in the cyanoatrial node. So they are not from the normal conductive system. It is originate from the atria. Therefore, at the contour of the P wave and the PR interval will be different. The timing are different, also the timing. Than the normally that is generated by the pulse from the normal conductive system of the front. And this is because of the origin of this impulse. It is from the atria, but not from the normal conductive system, not from the cyanoatrial node. So it will give us a different contour of the P wave when the PR interval will be different, and the timing is different. So here, if you see here at this P wave in this circle, the first circle, the time or the RR interval is not equal. This here, this is equal here and regular, but comes here, and the P wave morphology also different from the other P wave, and again here the same, it comes in a different time. That means this interval RR interval is not equal. Here this is premature atrial contraction, PAC. PAC. Okay, it is, I think, clear. And also we have premature ventricular contraction. We have to compare between them and no doing together. And I will talk about it. Okay. Considering, as I said, we have supra and ventricular tachycardia. Supraventricular tachycardia arrhythmias, we have, for example, if it is from the atrial, you can say atrial fibrillation and atrial flutter, and we have what's called paroxysmal supraventricular tachycardia. This is in brief. Definitely, we have another subtype of this paroxysmal supraventricular tachycardia, and we have a different form of atrial flutter. But in general, we have this. We can call them all of them supraventricular arrhythmia. This is an example of atrial flutter. Here, atrial flutter. What we have, the characteristic so towards appearance of the ECG. Here, the impulse, the atria come from the atria, and it gives this the characteristic so to shape like that. We have a lot of P wave. These all are P wave, and it's usually regular. This is called flutter wave. The PR is, you cannot here measure the PR interval here. The PR is, duration is normal, so this is atrial flutter with it is characteristic to sawtooth shape. The problem in the atrial flutter and atrial fibrillation is that we have no distinctive firing, especially in atrial fibrillation. There is a lot of points of firing, which is very chaotic. So that gives us a very irregular ECG change. And here, this is atrial fibrillation, definitely deviation from normal sinus rhythm. And here we have no organized atrial depolarization, so no normal P wave. But that's because the impulses here also not originating from the sinus node. Atrial activity is chaotic. We have a lot of points of electrical activity resulting in irregular rate. So they will be no organized P wave. or even no normal or no P wave. It's very common. It is affect about 2 to 4% of patients and up to 10% if in elderly patient, those more than 8 years of old. So it is very common problem here. You see, we have no P normal P wave here, no normal P wave, and the heart rate because there will be conduction. If you have atrial fibrillation, there will be ventricular response from this very chaotic and irregular P wave. Some of them definitely will conduct to the ventricle and give us the QRS complex. The way of conduction is very irregular, so the RR interval will not be equal, will not be have. It is very irregular like that. R interval are not equal. You see them here. So this is atrial fibrillation. You can easily diagnose it. There will be no P wave, yeah, no P wave, normal P wave, and RR interval is not equal. It's irregular. So if this is atrial fibrillation. About paroxysmal supraventricular tachycardia, also deviation from normal sinus rhythm. The heart rate suddenly speeds up. That means and often triggered by premature atrial contraction. Here it's not seen, and the P wave are lost. There will be sudden onset of increase heart rate, as you see here. That is the normal heart rate. Then now it starts speed up with the rate of more than 160 and regular and no P wave. It is regular and the rate of 100. So this rate of more than 130. So this is 60. So this is supraventricular tachycardia, paroxysmal supraventricular tachycardia. Again, the ventricular conduction and the normal one and the normal ventricular conduction, the signal or the electrical impulse comes through the normal conductive system, and so it moves rapidly through this normal conductive system. You see here, this is a normal conduction. So what is the abnormal? Varies here the foci of, if you see the foci impulse, that means the cyanoatrial or the pacemaker start from the ventricle itself. So the signal move very slowly through the ventricle. For example, here from the right ventricle to the left ventricle, and it is very slow. If you see, this is an example of premature ventricular contraction. Here we have a normal uh, ECG here before this abnormal one come. Here is the rate is 60 beat per minute and regular. But when it comes to the 7, it is occasionally irregular. So we can call it irregular rate. The P wave normal here, but here it is abnormal. Huh? And the PR interval also normal. The QR duration normal is, but in the 7th here it is wide. So what is this? You have a different shape QRS complex with wide QRS complex, and we have here negative deflection, and here it is negative and bizarre shape and different from the other QRS. So this is sinus rhythm with premature ventricular PVCs. We have premature atrial contraction, and now we have premature ventricular contraction. I hope you understand this very well. Ventricular arrhythmia, you have ventricular tachycardia and ventricular fibrillation in simply. Uh, this ventricular tachycardia can be further categorized and subdivided according to its cause and to its shape, to, for example, to monomorphic, polymorphic, like that. But simply we have to understand it is a deviation from normal sinus rhythm, and the impulse is originating here from the ventricle. No, so there will be no P wave, and the QRS complex will be very wide as you see here. It is very wide QRS complex, and the rate is very rapid. This is ventricular tachycardia because here the impulse is originating with a rapid rate from the ventricle, and so giving us what is called ventricular tachycardia. And ventricular fibrillation, it is completely abnormal here, and definitely it's originating from the ventricle, but in a very chaotic way everywhere with no effective contraction, and it is irregular, and it is just serious, and this is what's called shockable cardiac arrest. Either if there is no pulse in ventricular tachycardia, pulseless ventricular tachycardia, or ventricular fibrillation, this is called shockable cardiac arrest, or with a shockable rhythm, that we can use the DC shock to revert it to the sinus rhythm, and it is a fatal, and it is a type of cardiac arrest that is called shockable rhythm. Okay, talking, I think we have to stop here. We have and that ECG change that occur in valvular heart disease. If we talk about the aortic stenosis, definitely here we'll see left ventricular hypertrophy. So the change of the ECG, definitely we have feature of left ventricular hypertrophy, and it occur in about 85% of patients. And also there will be a change, as you see here, and this is a feature of LVH in this ECG. That means if you count the S wave in V1 and the R wave in V5 or V6, it is more than 35 millimeter. Okay. Also, in mitral stenosis, usually mitral stenosis is accompanied by left atrial dilatation. Left atrial dilatation, and we have what's called P mitral. P mitral. What's that mean? Usually we look here at B P at lead 2. In lead 2 here, this is lead 2. You see clearly we have a bifid. We have a bifid uh, P wave. This is a bifid P wave here. Okay, bifid P wave. That is a P mitral, for example. That's commonly occur in mitral stenosis. In addition, also the patient with mitral stenosis, most of them will have atrial fibrillation and are right ventricular hypertrophy, especially those with long-standing atrial fibrillation. RV had hypertrophy due to severe pulmonary hypertension that accompany long-standing mitral stenosis. Uh, ECG in the set of acute pulmonary embolism, commonly we have find there will be normal ECG, or the frequent finding is sinus tachycardia. Up to 70% of patient or 73% of patient, they will be sinus tachycardia or P pulmonary, that means right atrial dilatation and right axis deviation. And the common finding, that's what's called S1QT3 S1QT3 pattern. That is very specific for pulmonary embolism, found to from 11 to 50% of patient. And we could also find right bundle branch block or atrial flutter, and or normal ECG change in up to 24% of patient. I will show you here what is the S1QT3 pattern. Look at here. Look at lead 1. We have S wave. This is usually, there should be no S wave in lead 1 normally. And look at lead 3. This one we have what's called Q. We have Q wave here and T wave. This is very characteristic for pulmonary embolism. In acute pericarditis, we have the most important diagnostic tool is the ECG. And that is the classic finding is ST, diffuse ST segment elevation in all lead except AVR and sometimes V1. It's cuffed shape, it's cuffed upward, so it is cuffed upward, and the PR segment depression is also common. Okay, this change will revert to normal in maybe up to weeks. This is an example of pericarditis. We have diffuse ST, saddle shape ST segment, saddle shape ST segment elevation. Okay, in cardiac tamponade, we have called what is called here in this. If you see this, if you look at this ECG, all the problem here, low voltage ECG. It's very low voltage ECG. This is number one abnormality, and we have what is called electrical alternance. That is, you see here, this is P wave, and another P wave is a different is a different amplitude. You see this one, and this one is smaller. This is electrical alternance. In the CVA also you could find a change like ST segment elevation, and in about 70% of patients, especially in subarachnoid hemorrhage, you can find ST segment elevation and depression and T wave abnormalities and prolonged QT interval. All these changes can be found in subarachnoid hemorrhage. Okay, thank you. And we can uh, talk about different ECG and how to interpret ECG in a separate tutorial, inshallah. Thank you very much.